The broadcast is now starting.
Good morning or afternoon, depending on where you are. Welcome to the engagement, retention, treatment, and recovery of transition-aged youth, presented by the AspenRidge Recovery Training Institute. And we're planning to be together from now for one full hour, from 12 to 1 Eastern Time. And we're so glad that you all could join us from all over the beautiful country. We've got a great day here in New Mexico, very windy, but delightful to be able to be with you all for the next hour or so to talk about this really important topic. So just in terms of some logistics for our webinar presentation today, everyone right now is in listen-only mode. So we'll show the process for submitting your questions and comments on the next slide as we go through the presentation. If you're on a phone connection, then we have sent you an audio pin so that you can access audio and participate in the conversation. We have a helpline on the next slide in case there's any technical difficulties for you to utilize. The presentation is actually being recorded, so it'll be available on the AspenRidge Recovery website. There are continuing education units available for this presentation through the New Mexico Counseling and Therapy Practice Board, the Texas Social Work Board, and the Texas Licensed Professional Counselor Board. So if you would like CEUs from one of those boards, please send an email to viapositiva@prodigy.net. And then lastly, in terms of logistics, we're going to provide the slides today from this presentation to everybody who has joined us for this presentation today. During the presentation, if you have any questions at all, there's a chat box typically in the lower right-hand corner of your screen, and you can submit questions there, and then as the questions come up, I'll pose those to the presentation panel today so you can hopefully get a response. If we don't get to everybody's question, we will respond to your questions via email. We really appreciate your participation and your questions around this, really important topic of transition-aged youth. So you'll see also in the last bullet that that's the phone number for the GoToWebinar platform, 877-582-7011, in case you need any help with the GoToWebinar platform. We are very happy to have a group of distinguished presenters with us today from the AspenRidge Training Institute. Ethan Castro has spent the last 2 decades focused on building and growing mission-driven organizations within the healthcare and education sectors. Ethan grew up in Fort Collins, Colorado, where he attended Rocky Mountain High, and he went to college at the University of Colorado at Boulder, graduating summa cum laude and Phi Beta Kappa. Ethan holds a master's in education from Loyola Marymount, an MBA from Kellogg School of Management at Northwestern, and a JD from Northwestern School of Law. When he's not spending time with his wife and young daughter, you can find him skiing, hiking, biking, on the fields around Denver, playing soccer, or exploring the world with family and friends. So we're very pleased to have Ethan and his extensive background with us today. We also have Jeff Burt, who's the clinical director of AspenRidge Recovery at their Lakewood locations. And Jeff holds a master's degree in counseling psychology with specialized training in Adlerian psychology, motivational interviewing, medication-assisted treatments, cognitive behavioral therapy, and trauma-focused CBT. He's been passionately serving diverse populations, including transition-age youth, struggling with addiction and mental health issues for over 17 years. He's also an incredible true world traveler with passport stamps from more than 40 countries. And so we appreciate having Jeff's expertise and passion for the topic present with us today. And lastly, Marty Rain, PhD, LPC. Marty believes that the effective counseling is influenced by the therapeutic relationship. The ability to connect and feel compassion without being judgmental being a key factor in successful counseling. He's had extensive life experience as a counselor, supervisor, professional musician, and teacher. And he holds a PhD in education, and human resource studies with an interdisciplinary focus on human development and family studies, and a master's degree in education and human resources. So I think you'll find through our presentation both the passion, compassion, and clinical expertise needed to engage and retain transition-aged youth is evidenced in our wonderful panel of presenters today. And it's a joy for me, Jim Clarkson, the CEO of Via Positiva and Senior Advisor to AspenRidge Recovery, to be working with them today on this presentation that was actually requested by many people around the country who are dealing with the challenges and opportunities of transition-aged youth with mental health and substance use disorders. So I think we're in for a very pleasant and enlightening experience today. One of the reasons that we feel like this is a really important population to specifically focus on is that many of you may know, or some of you may not know, that 75% of all mental health and substance use disorders are diagnosable prior to the age of 24. And we know that typically diagnosis happens much, much later, if at all. And the loss of human capital, relational capital, creative capital, spiritual capital takes its toll when people have to live for many years with undiagnosed substance use disorders and mental health disorders. So it's so important to focus on this powerful and oftentimes very with a lot of people with a lot of needs in this transition age youth category. We know that early age and appropriate individualized treatment are critical. Studies have shown that adolescent brains continue to mature and develop until the age of 25 or 26. So we know that adolescent and young adult treatment has to be experiential and individualized to appropriately engage and retain transition-aged youth. We know also that studies have shown that up to 92% of people in publicly funded treatment report significant trauma. And we know through the Adverse Childhood Experiences study and many others that there's clearly a correlation between trauma, substance abuse, mental health challenges, and chronic health diseases that develop over the arc of a person's lifetime. And for that reason, we believe that intervening and getting the appropriate treatment to transition-aged youth gives them the opportunity to form healthy relationships, learn skills to navigate the adult world, and presents them with opportunities by developing a community of support so we can bend the cost curve towards a healthier population over the course of a lifetime. So without any further comments from me, again, I just want to welcome everybody. And at this time, it's my pleasure to turn the presentation over to Ethan Castro, the CEO of AspenRidge Recovery. Ethan?
Hello, Jim. Thank you for having us. Thank you for that introduction, and thank you everybody for joining us today. We have a couple quick slides just giving everybody here an overview of AspenRidge and who we are and what we do, and then we'll jump into the meat of the presentation here with Dr. Ryan and Jeff Burt. So AspenRidge Recovery is an outpatient mental health trauma and addiction treatment provider located, of course, in Colorado with 2 locations, one in the Denver metro area and one up north. Our staff is primarily master's level duly licensed clinicians, purposefully, so that we can really treat the co-occurring issues and illnesses that are a very present part of our population. Our core focus areas really revolve around 3 ways in which we're really kind of focusing our care, and one is providing support to our clients. The second is providing opportunity to our clients, and the third is helping them build strong and lasting relationships. And a lot of what we do is really focused on those 3 things in one way or another. Our 3 levels of care, of outpatient care, may last up to a year or more. Really very much depends on the individual that we're working with. And so roughly 3 months of what we consider day treatment. Some people call PHP. It's somewhat similar, not quite the same as what many payers would consider to be PHP, but day treatment with recovery resident support for roughly 3 months. And then moving into evening IOP for roughly 3 months, and then transitioning to evening outpatient for as long as necessary to really ensure that that person, our client, is put on solid footing. Next slide, please. So in terms of aligning business with clinical practice, it really revolves around the fact that our core clinical philosophy is that clinical quality needs to drive the organization. It is our definition of success in the purest sense, and ensuring that we have the highest possible clinical quality will ensure that we have better outcomes for our clients, for our patients, which will lead to a sustainable business. And that is really the thing that drives us more than anything else in terms of what we are doing as an organization. It needs to be the core driver. And so what this means in practice is that clinical directors, two of whom you'll meet today, of course, are our de facto leaders at each center. We do not have an executive director. Our clinical directors drive the centers and the work that we're doing, both clinically, primarily, but also operationally in many ways. We do employ an empathetic disease model approach, which means no behavior modification, not really a punishment model, as some have employed, and we find to not be useful. We focus on, of course, mental health and trauma issues as much as the addiction itself when needed and where appropriate, which we find to be quite often. And then last but not least, we invest in and empower qualified and capable staff across our continuum of care in the outpatient space. So that is it for the quick overview on who we are at AspenRidge Recovery. I will pass it on to, again, Jeff Burt and Dr. Marty Ryan.
Thank you, Ethan. My name is Jeff Burt. I'm sitting here with Dr. Marty Ryan, and we are both the clinical directors at the two different Colorado locations. Marty is up in Fort Collins, and I am in our Lakewood location. And like Ethan said, when we're not doing webinars, we are typically fairly, engaged. We spend a good portion of our days working with clients, running groups, and providing guidance to our therapists and interns. We really stress the importance of having a healthy community and keeping that community strong, because the community plays such a major role in helping our clients. Today, we've been asked to talk about transitional age youth. And for the purpose of this program, let's define what that means, because there are some different definitions that are online. But for the program today, we're just going to be talking about clients in the age range of like 18 to 25. And it's more important to focus on the transition than it is the age. We're talking about this transition from adolescence to adulthood, and also from dependence to independence, and the dynamics that kind of go into that. And it's a broadening stage of development, and we'll explain why later. And online, we've seen it explained as a period of emerging adulthood, and then I've also seen it referred to as adultolescence. Next slide, please. At this point, I want to insert a case study, and we're gonna talk about Thomas throughout our presentation. He's been so gracious to let us use his case as an example for our program today. Thomas is a 24-year-old Caucasian male who has a long history of substance use disorder and mental health issues. Before getting to us, he had been in several different facilities for mental health and substance use disorders over the last 2 to 3 years. He was really struggling, and one day he picked up the phone and called his mom. His mom directly got on a plane, drove out, and picked up Thomas and drove him straight to our facility. I knew there was some tension in the relationship when I saw Thomas's mom leave the facility just about 4 or 5 minutes after she dropped him off. That's usually not a very good sign. When I had met Thomas for the first time, he was pretty drunk. He'd been up all night doing cocaine, fairly grandiose, very verbal about his resistance to treatment, really anti kind of treatment, anti kind of 12-step, any kind of group stuff. Our first couple hours were spent kind of letting him vent, slowly building trust with him, to trying to get him into detox. We did get him into detox. Upon his return, he was a little more calm and reasonable. He kind of knew how to play the game. And our therapists, our clients in our community are really good with new clients and giving them kind of a wide berth so they feel comfortable, so they can express themselves freely. We're not in the business of getting any power struggles with our clients, and we really want to hear our clients' current perspective. So through this process, this early process, we came to learn that Thomas had an addiction to cocaine and ecstasy. Wasn't really sure about his relationship to alcohol. Was kind of on the fence about that. Presented with a ton of confusion about his life. His life was just really one big loose end. Significant periods of low mood and some mood swings that he was really effectively masking with like a very inflated sense of self. Did have some legal issues and was probably looking for a letter from us to get us out of some trouble, and seemed to have some internal motivation because he didn't really need to be there. So he was there, and you could kind of sense with him he was wearing down. So this is where we start with him. So the first thing I want to go over when we talk about this transition period, oh please, next step, thanks Jim, is some milestones that we see during this transition period from adolescence to adulthood. The first thing that we see, and is most obvious, is this progressive independence, which is this movement from this movement out of the parents' house into kind of a productive style of life, whether that means starting school, finishing school, having a career, being able to financially take care of yourself. I mean, having the industry, having the drive, having the motivation that's built through your adolescent years to kind of be able to launch into this style of life. And it's really at this point where most people would say, hey, for the most part, you're adulting now, and when most people come in and clients get jobs and start paying their own rent, that is seen as like a period where they're starting to move towards adulting. And we can use Tom and go back to Thomas's example. Like there was a period of time where he, after a treatment episode, he had spent 5 or 6 months working at a hotel, and he was working. He had explained that he was working probably 70, 80 hours a week, and he also explained that he was miserable. But from if you stand far enough back, it looks like, hey, he's responsible. He's taking care of himself. He's adulting, but it becomes very obvious fairly quickly. I mean, for him, he lasted 6 months just kind of working in that area, that these other 3 areas are super important to progress and to transition into becoming a mature adult. Yeah. So the next stage we're looking at is the ability to kind of have control of yourself and to be able to self-regulate. This is super important in the process of becoming an adult. You need to be able to show some self-discipline, to be able to resist impulsive decision-making, to be able to delay gratification, and to consistently take responsibility for your life.
These are some of the things that they don't have a lot of experience with at that point in their lives because they've never had to take that responsibility.
Never. Yeah, they've never been asked to take responsibility because typically someone is taking care of a lot of their life for them. The next step, which is another big step, is connectability. And having the ability and the willingness to form these relationships, to form healthy relationships outside of the family system. And like I said, this is no small step. Like the having the interpersonal skills and having the ego strength to be able to form these relationships and maintain these relationships. For most of our clients, it's just to be able to tolerate, an intimate relationship. And as we know, and as we hold very important in our program is the importance of healthy human connections, is essential to recovery, and it's essential to people's lives.
That sense of community becomes a core part of their recovery process,
and it becomes like a really good kind of benchmark to where they're at in the recovery, is kind of getting an idea or a feel to where they are in relationships to their community. If they're still on the fringes, then we know that we still need to kind of work on, the interpersonal skills or the ego strengths to kind of get them to move closer in and become more willing to connect with people.
And just along those lines, a lot of these young adults at this time, they're being asked to separate from their long-term relationships.
Absolutely.
Because they may or may not be healthy, and so they're having to make this decision about, okay, who do I allow into my bubble and who do I not allow, and that sort of also compounds that sense of fear of social competence, basically, of I don't know if I know how to develop new relationships, let alone an intimate one.
Oh yeah, they go through a lot, and the last thing is that developing self-identity and having a healthy relationship with self, and feeling grounded in healthy core beliefs. We find this to be something that typically will take place, and become more established during the adolescent period, but sometimes it doesn't get established, and we need to kind of go back and work with them and solidifying some of these questions like, who am I and what is my place in the world? So as we see, like the first step is probably the easiest. The last three are pretty significant tasks, and getting a good treatment provider can help provide that base. And this is why we see great reason for, attending a program that is 90 days plus, because these steps take a significant amount of time. Next slide. I can quickly go over some of the things that we're seeing as kind of some social trends that are maybe contributing to the kind of the slowing of this population in this age group. We're seeing an increase in age of marriage. We're seeing increases in age of death. So the thinking is that possibly these men and women are possibly extending kind of their years of irresponsibility and kind of waiting to grow up. Yeah. As an excuse. There is also, and it's true, there's a higher cost of housing and education. The student debt has gone up 53% in the last decade. So that, the price of education is getting greater, so that decision becomes harder to make. We're also seeing with this age group, a significant struggle with committing to a job or a career. We're seeing a lot of these men and women doing a lot of job hopping, kind of underemployed, kind of a lot of horizontal move between kind of menial jobs, struggling to determine, or settle in on a career and make a commitment to a career. The next thing we're also seeing from a societal standpoint is potential shift in parenting style and philosophy. Kind of the theory or the idea of helicopter parents, parents that tend to kind of overprotect their children, which makes it really hard for them to struggle in adult life when they've been protected or overprotected or kind of kept away from struggle in their childhood or in their adult life. Adolescent life. Marty's going to talk a lot more about that when we get down to the family systems. Yeah. The next thing is we're seeing and have seen a change in gender roles, and this is something, we're definitely, these men and women are growing up in a society that is a lot different than, my grandparents and parents. I'm a little older, but definitely there are different gender roles, and this can be confusing and it can kind of slow their process of their transition if they have some confusion about how they should or want to show up in the world. And more of the data is pointing towards men having a lot more trouble with this transition than women. Next thing that we're seeing is the highest risk of them being uninsured in this population. Which is prolonging the time it's taking for them to get help with mental health issues. And there's not really that motivation when you're stuck in kind of a protective bubble, possibly at your folks' house, and you're not being asked to do too much. It's easier for mental health issues to kind of be pushed aside or ignored for a longer period of time, and they worsen.
And it's part of that process of enabling an enmeshment that we'll get to a little deeper later, but they become protected from the consequences of not dealing with their mental health or their substance use or their differentiation process. So there's like this safety net, so they're never asked to do any of these tasks, or rarely asked.
So there's no motivation. There's a lot of fear about stepping out of that bubble. And the last thing that can't be ignored is the negative influence of social media and electronics. I mean, it is very powerful and is very real. You know, it has a very real effect on people's expectations and worldviews. So, next slide. So what we're seeing, so when we get clients and what we see, some common things that we see with our clients, signs and symptoms is the first thing, and probably the most obvious thing that we see is that they are still living with and or off their parents, which seems to be a rising trend in our society. I think we were running into numbers right around the 40% of men in this age range are still living with their folks, and 32% of women in this age range are still living with their folks. In the case of Thomas, he was actually living independently. His folks lived on the West Coast, but they were still paying for his rent, most of his rent. They were paying for his phone, and they were paying for his car insurance. And he was 24 years old. We're seeing a lot of indecisiveness and an inability to make decisions. So there's an inability to kind of commit to something, and to kind of dependent on others to make decisions for them. So this is a period of life, a transition period of life, where a lot of big decisions are kind of put at your doorstep, and not to recognize them, or not to address them, or at least realize that these are decisions that need some time, can be really stressful. In Thomas's situation, I know that he went through the motions of going to college based on, just kind of appeasing his folks. Like he made that decision because that was his folks' value. And he got about, I think, 10 to 15 credits short of like graduating, and decided to self-sabotage and not graduate because he decided that he didn't want to do the career that his folks wanted to do, but he was going along with it for up until about the middle of his junior year.
So that impulsivity sort of became part of his MO, because instead of finding a better solution and maybe a different career path and changing majors or something like that, he just impulsively dropped out of school.
Just quit. Yeah, just left. We're also seeing a lot of big egos, a lot of feelings of self-importance, some grandiose expectations that we could, probably directly or indirectly, connect back to some social media. They're unwilling to take, that we always hear this, where they're unwilling to take jobs that are below them, when they haven't had many jobs over their lifetime. Their best explanation for this is typically like, this is just a period of self-exploration. I'm going through a selfish phase. But it definitely presents as more like a mask to mask like the pain and the distress that we know that is there. The next thing that we're seeing is a lot of impulsivity. This is definitely a period of time where we'll see impulsivity, not following through with anything, with their plans, making poor decisions quickly. And when you follow these poor decisions, it almost always leads to the easier way. Finding the easier way is something that addicts do well. And we'll talk a little bit more about the contributors that could be attributed to brain development. But there's also, with this population, a lack of self-discipline. So, simply said, we're also seeing a lot of untreated issues with mental health issues and trauma. and untreated, and Marty, have untreated,
overtreated, undiagnosed, misdiagnosed.
So they go and they kind of they'll see a psychiatrist and they'll diagnose them with something. They'll take medications for a week because their parents make them, and then they stop taking them. So in the case of Thomas, like I think he had so many different, from ADHD to bipolar to borderline personality disorder to general anxiety disorder. There was a list of when we did the research back through some of his past placements of just several different mental health disorders.
Several guesses.
Basically guesses, and people throwing medication at these guesses. The signs and symptoms, are hard to detect. I mean, if you have a person, a son or daughters that are living with you and they're living in this protective, it's hard to tell when they're depressed or anxious, or because they're in that protected bubble. So it's harder to detect. And then end of the day, when you have all this internal stress, this indecisiveness, this impulsivity, you're feeling out of control, the stigma of living with your parents, you're going to feel distressed, you're going to feel uneasy. So the next thing you reach for and you come in contact with is drugs and alcohol, and it's a quick bond. I mean, it's a quick answer. And this is the point where we typically meet these people at AspenRidge. Next slide, please.
And so, this is just all supporting the evidence that's come out that this age group is becoming quickly to have the highest proportion of illicit drug use, binge drinking. And one thing that I've noticed here is earlier onset of experimentation with different drugs. So it is becoming a problem, and in the foreseeable future, we don't see it going anywhere but up.
In the next slide, thanks, Jim. We are, recognizing some increased, some things that will also increase the vulnerability of these clients to develop substance use disorders. When we talk about the mental health issues, when we talk about 36% of these clients from 16 to 25 having co-occurring substance use disorders, these clients are finding that that these street drugs, or drugs that they get from their friends, or alcohol they get from the store, or marijuana they get from the store, they work. They're effective on some levels in self-medicating some of these symptoms, but they're definitely not a long-term answer. They're a horrible answer to real issues. Once the bonds set in, with these drugs, it's hard to break the bond.
Well, and they become the person's best coping strategy. So, kind of a catchphrase in treatment is you need better coping strategies. And the bond that happens with that dopamine response, the pleasure system, it becomes so entrenched in the person's brain functioning that it's very difficult to break, because the drugs and substances actually become their best coping strategy for everything that happens to them that's negative.
Mm-hmm. And once the bond's set, it's difficult to break. We're also seeing a lot of neurological evidence. This is a distinct neurobiological period of life for this period of life, and like Jim had said at the beginning, your brain continues to grow till age 25, and during this period, neurologists have found that a reduced ability to appraise risk, increased impulsivity, and that they have significant implications on the brain's reward system, which puts them at higher risk of addiction. And beyond that, we're also seeing newer research around, they're doing MRIs of teenagers and seeing positive correlations between screen time on electronic devices to the dopamine and the reward system of our brain, hence, priming teenagers for addiction. An interesting study showed that 50% of teenagers asked, 50% of them admitted that they were addicted to their phones. And when asking their parents, more than 50% of them admitted that their children were addicted to their phones. Addicted. we reserve that word for something that is very serious. So when you're saying someone is addicted, that is time to take some kind of action. You know, and we get this when people come to our treatment center. The thing that freaks them out most, and Thomas also, was the idea that we were going to take their phone away from them for the first 30 days. A lot of centers won't do that, and unfortunately, some people looking for services will choose facilities based on how quickly they get their phones back. Mm-hmm. We feel very strongly about taking their phones for the first period that they're there, and giving their phones back to them slowly, just for short periods of the day, during the second phase. And in the third phase, they get extended periods with their phones. But we understand the importance and the power of the phone. Next thing, we're seeing that drugs are becoming more readily available. In this age group, we're seeing increased access to prescriptions. They're writing more prescriptions to this age group without proper assessments. Example is Adderall, but we can also use, opiate pain medication. Recreational drugs are obviously becoming more available, via legalization, via the dark web. The next thing that has to be recognized is that drugs are becoming more powerful. So that bond is becoming, it's happening, more quickly and more intensely. When you look at marijuana, the THC levels are at 80, 90%. Or you look at drugs like fentanyl, which is showing up all over the place. In heroin, it's showing up in methamphetamines. And we're still not sure, we still don't understand the long-term effects of electronics now. So when we go back to Thomas, he when he showed up, like I said, he was suffering with a lot of different mood swings. So he definitely had some underlying mental health issues, and depression was one of them. After about, and he admitted that the depression and the mood swings were helped by the alcohol and the cocaine. It helped him to manage some of the symptoms. It helped him to feel more calm. It helped him to feel, more alive. But after about 4 or 5 weeks, the underlying depression really surfaced, and it got really intense for him. And at that point, Thomas ran from treatment and went and relapsed. And we see that, and you were gonna.
Yeah, especially, there were a couple of things that happened with Thomas when that situation came around. Is that it takes about 30 days of a person being away from their substance of choice to really experience what their baseline functioning is. And so Thomas had this underlying depression that came up, and he didn't have another way to deal with it other than going off and using. But the other significant thing that happened, so most people would frame that as, oh, this is a very bad thing. And of course, everybody was concerned that he chose to walk off the treatment center. But something significant happened for him is that he actually, for the first time, decided to come back under his own power, under his own decision making. And that happens quite often because we create that sense of community where people feel safe to come back, even though they may have sort of done something that they think we won't like. Mm-hmm. And so while it was a very concerning incident that happened, it turned out in his case that he made a significant shift in his thinking by choosing to engage in treatment on his own through his own decision making.
Mm-hmm. Go to the next slide. And this, it kind of feeds into the idea of resistance, being resistant to treatment. And Thomas was highly resistant when he showed up. And we're going to quickly move through this. Some of these barriers, because we see a lot of these with all addicts. With this group, age is definitely a barrier, because the idea of getting your head around being sober at such a young age for the rest of your life is a really hard task. There's fewer tangible consequences because they're younger, so there's less legal. We see a significant amount of legal issues, less medical, less relational. Not a lot of them are married. And not many of them have careers, so there's not much consequence when it comes to vocational. Substance abuse behaviors. Within this age group, a lot of the behaviors, like the extreme drinking, the blackouts, are seen as more normal. Some of these behaviors are just more accepted in this grouping. Fear is a barrier for all addicts. It's a little bit different when it comes to this age group, because the fear really starts when they start to contemplate the moving out of that bubble, and when they're still in that bubble, they're still present as indestructible and fearless. It's just when you kind of coerce them out of the bubble that they really feel some intense fear. And last thing is the enmeshment, the idea that they're going to be pulled back into the bubble, or coerced back into the bubble by the people that don't want them outside the bubble. And Marty's going to talk more about that in the end. And like Marty said, like the huge turning point in Thomas's treatment was when he showed back up at treatment, and his parents were outside themselves, because they and I guess I didn't realize the significance until I talked to them, that was the first time that he had ever walked back into treatment independently.
And so it changes the loved one's perception that they can make good, that addicts, people struggling with substances in this age group can make those decisions on their own. And so it turned out to be a huge shift for his parents as well.
It was a huge decision. So here we're going to start talking about like what, some things that we do with our clients and how we approach the clients in this age group. The first step is to build traction with these clients and to remain non-judgmental. We want to remain non-judgmental with all our clients, but with this group of clients, that can be a difficult group to work with, because they come in, they know it all, they know what they need. They don't, they're so conflicted. They want to be there, they don't want to be there. So being able to stay in touch with your other therapists and check with yourself and keep yourself healthy working with them. And like we always say, they're very slow to trust and quick to run. So making sure that, the process of getting them to trust us and giving them some flexibility in their treatment to help them understand that we're going to work with them, and that we're able to work with them, and reducing the stigma is another thing that becomes a really important part of this, because getting sober at that age is hard. It's not cool, that's for sure. And it becomes part of their personality. Like they become that personality, they become that guy, and they have a lot of power in those different drug arenas or those different club arenas. And
so they're afraid to let go of those relationships because they're afraid they won't have power in their next relationship, or the stigma of being in recovery is going to hinder them from developing those social relationships. And so if you do a little research, there are plenty of groups, including us, that sort of promote working on changing the public opinion and stigma of what it means to be in recovery, to sort of counteract that belief system.
Yeah, the new Sober Curious movement is a great example.
Curious.
Just helping them work through. I always like to ask them, if this were up to you, would you be here? And they kind of know it's a trick question, but they're smart enough not to say no. So it's like gets them to think like, there's a part of them that wants to be there, and you have to get in touch with that. You have to get in touch with that pain and that confusion with them. So always being flexible and hopeful. Like the hopeful piece is always being like, always having something to offer them, always knowing that this is not where they want to be in their life. As much as they want to convince you, they're young and they're wily and they're resilient. So they'll push back and they'll look for loopholes, but constantly like being able to understand that they're going, that there's a part of them that is really struggling.
Well, and one of the tenets that we believe in is sort of a strength-based treatment.
Yeah.
And so when you think of those traits of wily and manipulative and things like that, how they've gotten their way, to try to instill that hope is to sort of point out that these strengths are things that they've been using to get what they thought they needed. And so it's not really that they have to get rid of those traits. It's just that they have to reapply them to a new directive, into recovery. So that hopefully instills a sense of hopefulness and encouragement that they start to believe that they can do this on their own.
Yep. And just so and working with them using CBT, we do this with all our clients, and using CBT a couple of times a week with our clients. With these clients, we find it, obviously a different set of core beliefs, a lot of thinking around self-importance, but also on the flip side, a lot of thinking around incompetence. So what do they say, like a egomaniac with an inferiority complex? So the same idea is being able to kind of write their thinking around, where they stand in the world, and be able to dispute some of that thinking. Addressing, effectively and competently addressing mental health and the trauma issues. It's hard. A lot of facilities will say, yeah, we can handle it, but not many can handle it. So making sure, that, at AspenRidge, a good number of our staff have a significant mental health background, and are competent. We've proven our competence with working with mental health and trauma. The next one is promoting discipline, and I'll say this quickly. It's with us, it's not about providing discipline, it's about promoting discipline and making the client understand the benefits of living a responsible life. We spend a lot of time talking about words like discipline, courage, justice, so they know, that you want them to want to lead a disciplined life. The next step is taking small steps, to build confidence, to build that self-regulation, to help them to kind of find a little victories, so they can say, like, oh, okay, I do have control. I do have the ability to regulate myself. Next step is key and driven home. And like I said, connection, and I've said throughout the whole program, connection is key. Requiring clients to get a sponsor, or requiring clients to have to go on coffee dates with others, or have a mentor. It's something that any program can't be without, is this drive towards connection and teaching interpersonal skills. And the last thing is preparing them for discharge, from the start, preparing them from discharge, always working on, living skills, recovery skills, confronting any kind of barriers with getting a recovery job, pushing towards sober living, because we see lots of great success with clients transition right from our services into sober living, into an evening IOP program. So constantly and consistently encouraging clients to kind of move in that direction.
So if we go to the next slide, it's kind of moving into this family piece. And so what Jeff's referring to is, the longer a person is engaged in the treatment, the more likelihood that person will enjoy a healthy long-term recovery. And when I say engaged in treatment, and I move into this idea about including the family somehow in this treatment, and I'm going to move through these slides fairly quickly, but families need to be included. Addiction is a family disease, and the threat of addiction finds its way into the family systems long before they've ever realized it. So the goal of family therapy is really just to improve those relationships of functioning, really help communication, boundary setting, address any special situations that are going on. But the family system of these transitional age youth can vary widely. So without going too deeply into it, I'm just going to encourage continued assessment. And what we do is weekly phone calls with our clients. But the functioning of the family system needs to be constantly assessed, because it will evolve. And it's hard enough to assess and guess what the functioning of the client is. But then when you add a mom or a dad or a husband or a wife, those family dynamics increase exponentially. So it can become very complicated in a very hurry. So it's nothing to rush into. Especially with this age group, confidentiality can be tricky. Part of that assessment should, of course, include if there's any trauma or abuse or something like that. So before involving families in this process, that assessment should be done. But with confidentiality, especially with 16-year-olds, that topic has to be discussed, and the area of what is to be disclosed needs to be discussed, and everybody needs to be included in that conversation. But of course, taking a balanced approach, not taking sides, and trying to have a sense of non-judgment. You know, and I put in there, nobody is enjoying this situation, because anytime a change is made in someone's life, they become uncomfortable. And in this case, the bubble that Jeff is talking about is this enmeshed family system where the family doesn't want to feel like they're getting, they don't want their job as caretaker to change, and the addict or the person struggling with drugs or alcohol doesn't want their dependency to change. So both people are very uncomfortable in this situation. So preparation for the family for the escalation of the client when they become uncomfortable, and actually vice versa too, because if the client starts to make boundary changes, the parents or the family members will start to be uncomfortable as well, because their role in that family system will become different, which will make it uncomfortable for them. And of course, try as best you can to not have secrets. And these are, you know, trying to create that sense of an open dialogue, just like we've been talking about with that sense of community. Except that when we build the community in the treatment center, we're kind of starting with a blank slate. When you try to create that sense of safety and community within the family, you have all of those scripts that have been being developed over time to deal with. So let's go to the next slide real quick. And I know this is getting to the end of our time, and we want to have some time for questions. And I'd be happy to answer any questions through email that anybody has. But I am going to skip down to about the fourth or fifth one down, where it says acceptance of the concept of co-recovery. And this is something that I had thought of quite some time ago, that this recovery experience is not necessarily just for the clients, it is for the family as well. And so for them to sort of buy into this idea that this is about their recovery too, and encourage them to have their own therapist or community support group that is well versed in codependency and the addictive threads that happen in a family's system as the addiction starts to weave itself in. One of the biggest questions for families that needs to be addressed, in my opinion, is this idea of support versus enabling. And so this recovery experience for addicts is fairly straight ahead. If you're using or not using, I'm either in recovery or I'm not. But for a family member, trying to separate out what is actually a supportive behavior and what is an enabling behavior can be much more nebulous to tease out. So that's really the main focus that I try to seek out in the family sessions. And of course, if I skip back up, many times it's important to do some individual coaching / therapy with the family members alone without the client there. So people are sort of brought in after they both have done a little bit of work, both entities have done a little work on themselves. So that was the fast version of families. So we're going to go from there.
And also offering opportunities to have like sessions with a family coach. We refer people out to family coaches. Let's just go let's go to the next one and check in on Thomas. I want to give you guys the finale on Thomas. Thomas did graduate our program after 110 days. He did well. I feel like he really made, I know that he made a lot of strides in trusting and taking more responsibility for his life. He decided to take a kind of a grunt job at a solar tech company, which was really out of his comfort zone. He was more into like the whole bar club kind of scene. He is still living in a sober living, which is great. He doesn't like it, but because it kind of cramps his style, living with a bunch of guys, but he's doing it. He texts me occasionally telling me how much he hates his job and hates his living, but I can tell just from knowing Thomas that he knows he needs to be, the part of early recovery that is a struggle. He knows that he's not making impulsive decisions. He's not leaving. He's not quitting his job. It's what he's doing. Sometimes what he's doing is right. What he's saying is like, I don't like it, but I'm going to continue to do it. He occasionally shows up on Tuesday nights for our alumni meetings. And continues to attend some community help groups and sees an individual therapist. So he's doing good. His parents are elated. He has a more solid relationship with his family. His family was very happy. with how the whole thing played out. And like I said, Thomas is still part of our alumni community, and he hasn't run away, which is a great sign. Jim, we got any questions?
So we'll just jump really quickly into the final slide before any questions that may be out there. We'll leave a couple minutes for that, and apologies for less time than desired for that. This is a busy slide, but the gist of this slide is as you can see on the left, the dark being not using, the dark color being not using. At intake, most people are using or abusing within the last 30 days, which is the question that is being asked there. At discharge, most are not, or have not relapsed, but some have. And then throughout, over that time, you can see that that inversion holds pretty steady for a while. But what we found is that longer outpatient stays, of course, leads to better outcomes. And so you can really see this in the circles on the right side. That upper one, 78%, is for those who 6 months to 2 years later are staying sober for having attended one or the other program, not both. But when people or clients or patients stay for both programs, you can see that 89% on the bottom right is really what we're seeing. So a substantial increase of 10+% when you have clients staying with us for 6+ months. And so it's definitely noticeable. Either way, they're improving, they're getting better. It's very, very good. But really, those longer outpatient stays lead to consistently better outcomes we're seeing. So that's really it for our presentation right now. Any questions out there?
Great, thank you so much, Ethan, Marty, Jeff. We really appreciate it. I want to just take the opportunity to invite folks to send us any questions or comments you might have. If we don't get to them, and we likely won't today, we'll respond to them via email or phone call. We'd really like to continue this conversation. We got a lot of information presented today, and we would really like to hear your ideas, input, and conversation as well. So everyone will be provided with this PowerPoint deck with our contact information so that we can continue to further the conversation and not only serving transition age youth and with treatment, but also the recovery services and across the country. So we look forward to having a conversation with you about that. And we do just have one question just in the last couple of minutes here. And the question is about serving clients from non-traditional or single parent families. If there's any information you might be able to provide about that, if, just in terms of people that may not come from a typical two-parent family, but maybe from a single-parent family or a non-traditional family.
Yeah, I can talk to that a little bit. It kind of goes back to that idea of assessment, and there are so many different variations of what a family system might look like. So depending on if it's a single mom or a single dad, or maybe an adoption, can also have an effect. But for people from those non-traditional families, like if it's a single parent household, really to assess that level of enmeshment between the client and their loved one family member. So a lot of times what I've seen when there's a single parent household, that parent is even more protective than they would be otherwise. It can also depend if there's other brothers and sisters. So the more siblings there are, the less attention there is to each one of them. So again, it kind of goes back to that idea of really including those family members in the conversation so that they actually have this idea that this recovery is for them too. A lot of times I tell people, when the person comes into a treatment center, that's a respite for the client, but it's also meant to be a respite for the family members or the loved ones as well, because they know their person is in a safe place, and that's the time for them to really have a chance to do their own self-exploration and work.
So really just including them in the process, just like it would anybody else, I think would be probably where I would start.
Great, thank you so much, Marty. And thank you all for joining us. We hope that these ideas and experiences will be applicable in your work that you do. We do want to continue the conversation. Especially want to thank Ethan, Marty, and Jeff for taking the time and sharing their experience so openly with us today. And with that, we will bring this presentation of the AspenRidge Behavioral Health Development practice to a close, and we look forward to hopefully talking with you all soon. If you'd like CEU credit, please just send an email to us and we'll send an evaluation and a brief quiz, and then provide you with a continuing education certificate for the presentation today. Thank you all so much and enjoy the rest of your afternoon.